Great. My name is Scott Bauer. I'm at the University of California in San Francisco. Thank you to the scientific committee and the chairs for having me speak today. I have no conflicts of interest. So we know that obesity is a risk factor for urinary incontinence in both men and women. That data is predominantly from younger men and women. And the reason that is important is because we have shown in secondary data analyses of randomized trials that both that younger men who are overweight and obese, who lose weight through lifestyle interventions or through surgical interventions, are less likely to develop urinary incontinence and have increased remission of their incontinence. However, it's unknown if these interventions are effective or safe for older men with urinary incontinence, the population of men who are most burdened by these symptoms. That's important because we know from a large geriatric literature that weight loss in older men is very complicated. Older men who lose weight are actually losing proportionally more muscle than fat. And when they regain weight, which is very common, they are regaining more fat than muscle. You can see that that cycle is very likely to lead to worsening sarcopenia. We also know that the mortality benefit of weight loss among overweight men is decreases with age, so that older men who lose weight have little or no mortality benefit. And in fact, we think that that is part of, it's been named the obesity paradox, in which overweight men who are younger are more likely to die, but older men who are overweight or obese actually have lower mortality rates. This led me to ask the research question, is adiposity and strength associated with urinary incontinence in older men? I used strength because measuring muscle mass is quite complicated, and strength is actually a very strong surrogate of this. In order to answer this question, I used the Health, Aging, and Body Composition study, which is a large prospective cohort study of both men and women. There's about 1,500 men enrolled at age 70 or older. They're reassessed every 1 to 2 years and are followed for more than a decade with excellent retention. For the results that I'm going to present today, we excluded men who have Parkinson's, stroke, or urologic cancers. Urinary incontinence is assessed with a recall period of 12 months. Among those who endorse any incontinence in the past month, they are then asked to further characterize the frequency of their incontinence as well as the type, as urgency, stress, or mixed. And we're using data for this study from baseline as well as 3-year follow-up visit. We defined adiposity 3 ways: BMI, waist circumference, as well as fat mass, as measured by dual energy X-ray absorptometry. And then strength was measured 2 ways: upper and lower extremity strength with dynamometers. Our primary outcome was urinary incontinence, defined as greater than 1 episode per month. And the reason we used that definition was lower event rates in this population. And although we've published the prevalence results, what I'm really presenting to you today is the new cumulative 3-year incidence results. And you can see the sample size is smaller in that group. So presenting both of these results, you can, I think, see a stronger picture emerge. We use multivariable logistic models. Adjusting for these covariates, we looked at a very extensive list and only included those that changed the effect estimates. Excuse me. So overall, we had 20% of men at baseline who reported at least monthly urinary incontinence. Over the 3-year period, among men who were continent at baseline, 15% developed urinary incontinence after 3 years. About half of those were at least weekly incontinence. And this was predominantly urgency incontinence with some mixed urinary incontinence. So on to the primary results. You can see this is both prevalence and incidence results presented together. The black diamonds are urinary incontinence prevalence, and the gray squares are urinary incontinence incidence. And the x-axis is odds of incontinence. So for BMI, men who had higher BMI were more likely to report prevalent incontinence and were borderline more likely to develop urinary incontinence. This was less so for waist circumference and total fat mass. Because BMI is such a strong risk factor and is highly related to waist circumference and fat mass, we wanted to look at the results adjusted for BMI to see if either of these factors were driving the association with BMI. And as you can see, there was no independent effect of waist circumference or total fat mass on prevalent or incident urinary incontinence. For our strength measures, Upper extremity strength was not associated with urinary incontinence. However, lower extremity strength was associated with urinary incontinence prevalence. And then adjusting for BMI, again, the results for lower extremity strength appeared independent of BMI. We conducted several sensitivity analyses that I don't have time to go over with you today, but happy to answer questions about. And in summary, older men with lower adiposity, defined multiple ways, as well as higher lower extremity strength, are less likely to have urinary incontinence. Associations are strongest for BMI and less so for fat mass and waist circumference. We observed weaker associations for incident urinary incontinence, but if you notice, they all trended in the same direction as prevalence, which I think tells a strong story. And lower extremity strength, which has not been studied before, may be as important as adiposity in determining risk of urinary incontinence in older men, which is important because men often lose strength as they undergo weight loss interventions. I'd like to acknowledge my funders as well as my scientific collaborators and my co-authors for the study, and happy to take questions if we have time.
Thank you. The floor is open for question.
Adrian Wang, Edmonton. Thank you, Scott. That was very elegant. Do you think that lower extremity strength just might be a surrogate for mobility?
That's a good question. I did not present the results here. We have looked at gait speed, and lower extremity strength was more strongly associated than gait speed was.
Right. And secondly, I was going to ask something else that I've completely forgotten. Damn. Short term. Oh, remission. What was the remission rate? Because there's always a remission rate, isn't there, when you have a 3-year...
Yes. Trying to think if I looked at that separately. Actually, don't know off the top of my head. I would have to look back.
Thanks.
Maybe a last question. Just curious about the upper extremity. I can understand the lower extremity being maybe linked with mobility, but why did you want to assess upper extremity grip strength?
Yeah, so grip strength is strongly associated with many important comorbidities in older men, and generally lower and upper extremity strength tend to track together and are suggestive of sarcopenia in older men. Thank you.
Thank you.